All right, hi everybody. So our presentation is going to be on knee osteoarthritis. So to start things off, we're going to talk about the diagnosis, impairments, limitations, and disabilities. So there are 5 grades of knee osteoarthritis, with grade 0 being a healthy knee and grade 4 being severe osteoarthritis. So the diagnosis involves a clinical exam that can then be confirmed by x-rays, and the clinical exam will include a subjective assessment for history of pain to see if it's consistent with the typical OA progression. And then there's going to be an objective assessment that involves observation of the knee at rest and during movement patterns and ADLs, gait assessment, palpation, ROM, strength, and balance. Then we can confirm that with x-rays to examine the breakdown of cartilage, narrowing of joint space, and bone spur formation. There's other diagnostic tests that include blood tests to determine the type of arthritis, arthrocentesis to sample the joint fluid, arthroscopy for visual examination of the affected joint, and MRI for better view of the cartilage. So impairments will include pain, decreased ROM, and decreased strength, with the limitations and disabilities overall just being reduced ability to perform ADLs as a result of those impairments.
Osteoarthritis usually develops slowly over many years in response to mechanical stress. It also depends on the joint that is affected and the amount of functional impairment. And then for our presentation, we're talking specifically on knee osteoarthritis. So the course of functional decline is generally slowly deteriorating function, but individually, many patients can improve or even maintain function during the first 3-year follow-up. Pain can also be a symptom of osteoarthritis, and exercise is an effective pain management tool. But once the osteoarthritis damages the cartilage, the level of disability increases. So, in the early stages of knee osteoarthritis, there can be pharmacological treatment, which involves oral, topical, and intra-articular options. And then there can also be non pharmacological treatment, which can include avoidance of activities, exacerbating pain, or overloading the joint, exercise to improve strength, both, and then occupational therapy for unloading joints via brace, splint, cane, or crutch, which can also be accomplished through physical therapy, and then as well as weight loss, since obesity is a very high avoidable risk factor. In PT, the treatment goals are directed towards pain relief and restoring function. But once a patient gets to a point where exercise is no longer contributing to their pain relief, a common treatment route people with knee osteoarthritis will go for is unicompartmental or total joint arthroplasty. Recovery can take about 4 to 8 weeks, and after the surgery, many patients have a better prognosis that can include the return of many activities they did before the diagnosis.
So, treatment options for these patients. First up, we have manual therapy. So, the research says that orthopedic manual therapy compared to exercise alone leads to short-term benefits, emphasis on that short term, such as pain reduction, increased function, and increased physical performance. It's important to note here that short-term benefits, like I mentioned, so this can help our patients get out of that acute inflammatory phase, but it's not going to have a long-term effect on their overall prognosis. And manual therapy here includes knee joint mobs, patellar mobs, soft tissue mobs, Mulligan mobs. So there's a lot encompassed in that manual therapy piece. So that's important to remember. Strengthening with a quad focus. Knee osteoarthritis patients often present with quadriceps atrophy due to the reflex inhibition from pain and edema. And quad strengthening is shown to decrease pain. But of course, hamstrings, calves are also important to strengthen, anything that can help support that degenerative joint. Closed chain and open chain exercises are shown in the research to have similar strength gains for patients. So one's not going to lead to more strength than the other, but closed chain exercises tend to have less shear forces on the joint and tend to be more functional. For range of motion, we have a flexion focus here just because of the capsular pattern of the knee tends to be more limited in flexion, so that's generally what we're going to be working towards, but of course full extension is also important for gait. And balance, so proprioceptors will definitely be affected by osteoarthritis. That synovial joint will damage those proprioceptors, so it's important to make sure we're addressing our patient's balance impairments. And continuing on that, we have some other options that might not be in the typical outpatient orthopedic setting, like aquatic therapy, which we just learned about. And this is great for patients who are in that really acute phase and have a lot of trouble weight bearing. We can take some of that load off of the joint and get them moving without putting so much pressure on the knee. And then modalities like heat or ice are inconclusive as to which one might be better or worse for patients with osteoarthritis, but both have weak evidence to help with pain reduction, increased range of motion. So it's up to us as therapists if we feel like leveraging the placebo effect or using that weak evidence based on anecdotal evidence of what makes a patient feel better. But one is not necessarily better than the other for the management of these patients.
So here we are looking at an example treatment session for mild to moderate knee OA. And for these, we want to really focus on increased range of motion, increased strength, and then obviously a decreased amount of pain for the patient. And with all these treatment sessions, of course, it's going to be individualized to our patient. But to start, we want to warm up potentially on the bike to get, the joint moving, to get some blood flow in there. And then we're going to transition into some manual therapy. We want to get some soft tissue mobs to the quads and the hamstrings, and then some patellar mobs and knee joint mobs. And all this together, we want to focus here maybe 15 to 20 minutes as tolerated. We don't really want to exacerbate any pain. So if any of these therapies do make it worse, then we would hold back. And then manual stretching can be effective depending on the patient's deficits. And then we're going to transition into the therapeutic exercise. And we're going to look at step ups, step downs, mini lunges, wall squats, heel slides, standing balance, and the straight leg raise with the ankle weight. And for step ups here, we're going to start with a smaller height and work up to that. We really want to focus on the functional movement first, and then transition into that higher height. And just to get going on the stairs if the patient has stairs in their house or just in the outside world. And then for mini lunges, our book has said that mini lunges are great if they have unilateral knee pain. It's a great functional movement if they need to pick something up off the ground. And then the heel slides will be great for range of motion. And then standing balance, we really want to get those proprioceptors back in play for our patient. And the dosage for all this, we don't want to be cookie cutter, but we do want to focus on that strength, especially in the quads. And so somewhere around 3 sets of 8, it'll be individualized for the patient and for each exercise, but we really want to focus on that strength of the quads. And then modalities, ice for pain and inflammation can be really effective with knee OA depending on the patient. And so if there is some inflammation or aggravation towards the end of the session, then that can be put to good use.
To measure patient progress throughout treatment, the Western Ontario and McMaster University OA Index, or the WOMAC, will be used to assess ADLs, functional mobility, gait, general health, and the quality of life. An ordinal scale of 0 to 4 will be used to score patients in pain, stiffness, and function, with an emphasis on function. As the patient progresses through therapy, we generally want to see the patient score lower, because higher scores mean worse pain, more stiffness, and more limitations. The test's retest reliability values are 0.74, 0.58, and 0.92 respectively for those 3 categories. And this means that this is a great outcome tool to use, especially when we're looking at and evaluating the function. So going back to our main treatment goals of restoring function and pain relief, the WOMAC will give us a good picture of how the patient feels and their ability to function and their ADLs and their pain levels. We can also track physical progress through range of motion measurements and strength testing. As mentioned earlier, patients will most likely come into therapy with limited knee flexion and diminished quad strength. And knee flexion is needed to perform ADLs properly with good biomechanics, and quad strengthening is shown to decrease pain. So by measuring both range of motion and strength, we can track physical changes as well.